Good afternoon, everybody. Welcome to our next session, Building a Broader Vision of Healthcare Data, a Multidisciplinary Approach to Understanding and Leveraging Social Determinants of Health Data. Sarah Woolsey from Comagine Health will moderate this session. Sarah?
Thank you. We'll just give a second on our sponsor. We have a unique session today. We actually have a speaker for the first portion and then a panel for the second portion. And then we're going to bring everyone together for questions at the end. I'm going to go ahead and get the file up. And I'll just have someone confirm that they can see it. Should be coming up. All right, are folks able to see Caroline Schaefer's first slide? Okay, all right. So again, my name is Sarah Woolsey. I'll be your moderator today. Our first speaker is Caroline Schaefer. She's a biostatistician at the University of Texas Health School of Public Health Center for Healthcare Data. She has been there about 12 months, a whole year already. And prior, she worked as a federal contractor for NASA's Johnson Space Center, focusing on astronaut health surveillance and research studies. She's going to kick us off with the impact of social determinants of health on reportable health outcomes, and we welcome her today. And for everybody who has questions for Caroline as they come up, begin to put those in Q&A, and we'll address those after she speaks. Caroline, welcome.
Thank you, Sarah, for the introduction. You can go ahead to that second slide because we've talked about the impact of social determinants. Again, briefly about me, I've only been here at UTHealth Science Center in the Texas Medical Center in Houston for, I guess it may be about 13, 14 months now as time has gone by. I previously worked at Johnson Space Center with both human health surveillance and also research studies. So I worked both sides of clinical health surveillance, but also astronaut research programs. So I'm used to both the idea of just health reporting and health and research programs as well. Currently, my work at the Health Science Center, I'm working on all sorts of projects from how Hurricane Harvey affected our vulnerable populations to anesthesia and maternal health outcomes to state reporting services using state Medicare and Medicaid claims data, and also social determinants of health. Next slide. A brief just tidbit about our Center for Healthcare Data. We have one of the largest health claims databases in the state of Texas. It has claims for approximately 80% of the insured population of Texas. We are a certified CMS qualified entity, which means that we have the access and we house the state Medicare and Medicaid data. And because we house that, we also do the reporting services, specifically a Health of Texas project, where we are creating a public-facing website that has cost, utilization, disease prevalence metrics, things like that, that policymakers and other providers within the state can use to look at their own possible research uses for our data. We do all kinds of projects from external quality reviews to cross-agency coordination for healthcare strategies and measures, along with your usual targeted research for clinical outcomes and economics and quality improvement, both through our internal researchers at the university and the medical center and the medical school here at UTHealth, but also outside researchers who are interested in our data. Next slide. So what I'm here to talk to you today is a study we did to determine the contribution of social determinants of health on population health. We use that database that I've been just referring to. That includes this Texas State Medicare and Medicaid data. It also includes a few commercial claims databases as well. And for this study, we looked at a few selected outcomes, health outcomes that we could attain from claims data. So specifically in this particular study, we looked at cost per member per year, emergency department visits, inpatient admissions, and a tool called 3M clinical risk group scoring, which is, I'm not sure if anyone is familiar with it. It's a tool that 3M provides that takes every medical claim, every pharmaceutical claim that an individual has for a single year or a certain time frame, and they're given a score from 1 to 9, 1 being very healthy, no kinds of chronic conditions, to 9 being catastrophic diseases or organ failures, things along those lines. So that's what the 3M is referring to. It's a numbering system for overall health. And then we used data called social determinants of health to create models to see how those social determinants of health affected cost, emergency visits, et cetera. We developed the social determinants, the many variables from previous publications that have already kind of really been looking at this. Specifically, I believe it's the University of Wisconsin's Population Health Institute started with a county rankings, but it also includes just statistics from the National Center of Health Statistics, your BRIFIS behavioral risk factors surveillance system, the USD food environment, all those types of things. And we looked at them separately for 3 different types of populations: your under 19 population, your 65 and over population, and then just the general population. The goal of this was really to propose a conceptual framework that we can give to policymakers, give to providers, to help them develop interventions that may be better targeted towards specific social factors or populations, and that can help solve maybe some of the disparities that we're seeing a lot in our populations. Next slide. Okay. So, but what are social determinants of health, right? I'm not sure if anyone is new to the topic, and you're here for this session to really learn about what are social determinants. According to healthypeople.gov, it's really the variables that go into helping a person make good health decisions, have access to good health interventions or access to good health care, and really the entire environment that a person is in that promotes good health, and what those kinds of variables are. Examples are access to healthcare services, food insecurity, quality of housing, social cohesion, access to exercise opportunities. And even though they're called social determinants of health, it's still, that physical environment is still an important role too. For example, like pollution or access to parks and exercise opportunities, things like that. So it's not just strictly social, even though that's in the title. It's still your entire environment, both social and physical. Next slide. Why are they important? Social determinants is a way that we can really get at how a consumer makes their decisions. We have plenty of things for providers and for health plans that have their own performance measures for quality, like HEDIS measures, disease rates, things like that, immunization rates. But sometimes a lot of those types of things, it's not just whether a person is sick or not, it's the decisions that the consumer is making to get an immunization, to go to see their PCP, things like that. And really, how can we quantify those relationships? I think the big part is, there's plenty of anecdotal stories of, well, if you live far from a place with easy access to healthy foods, vegetables, fresh vegetables, then you may have higher risk of diabetes, or being overweight, hypertension, things like that. But it's really trying to quantify those types of relationships between the environment and someone's actual health. Next slide. So for the purpose of our study, we broke down the social determinants because there are many. I believe for just this study, there's over 30. You could really grab every single one you wanted to. We're going to keep going through the process of refining which social determinants we look into, but initially we put them kind of into categories and created scores for each of those categories. Those categories for this study were access to healthcare. So it's usually primary care physician rates in certain counties, mental health rates, things like that, or mental health professionals availability as well. Health behaviors, your smoking rates in a county, health outcomes, which was a little more interesting because they're health outcomes that you could think of as an outcome measure, but they're still impacting an entire county of things like teen birth rates, STD rates, things like that. And then your physical environment, air quality, housing, et cetera. And then social and economic environment, which is what you would really kind of hone into, I think, with a lot of these variables of unemployment, children in poverty, food insecurity, things like that. And so that's kind of what we used for this step in our analysis. Next slide. So this is, I tried to get this as concise as possible. But so for this study, 5 different models were made, 5 different models were made, one for each of the outcomes. Cost, emergency department visits, and inpatient admissions were linear regressions per member it was all per member per year. And then for the 3M, because they're just 1, 2, 3, 4 scores, I used proportional odds models to create those models. Every model also adjusted for age, sex, and insurance type. Especially the insurance type was very important, just because you know, the qualifications that you have to be eligible for the enrollment in them often are health dependent, and also income, or also a social determinant if you think dependent. So we included those in the models as well. And from those 5 models for each outcome, we then used the coefficient estimates to create weights that we could use to form a conceptual framework. And next slide. And here is just kind of an overview of the outcomes for that. So the categories for each of the groups. So all it was is you just took all of the coefficients, those weights, and then averaged over the 5 different outcomes. So as you can see here for the under 19 group, they were the most different, I would say, from say the 65 plus and the general population. It was a more unique group of people. The 65 plus and general population often trended to have to be similarly affected or impacted by social determinants, whereas under 19 it was different, which makes a lot of sense when you just think about how when you're under 19, a lot of your healthcare decisions aren't made by you. They're generally made by a parent or caregiver. Whereas your general population, 65 plus, you have more people who are responsible really for their own healthcare decisions. And as you can see, the social and economic environment, so your unemployment types of categories, affected the under 19 group the most. Whereas the health behaviors and health outcomes was more impactful for the 65 plus and the general population. So you can see how the health behaviors, health outcomes, those are usually more of just what people are doing, how what they do affects their overall health. And social economic environment, it's more the world that, you know, a child is in, the environment that they live in really affects their overall health and their healthcare opportunities. And next slide, I'm going to go a little more in depth. So for each outcome, they all had their own weights as well, and it was averaged to create those previous scores. But for each outcome, the different social determinants had different impacts. So it's not just a magical across the board, you know, social and economic environment was the most impactful for everyone for every single type of outcome. You know, for the under 19, yeah, the social and economic was most impactful for cost and inpatient admissions, but so was the physical environment, you know, food deserts, air pollution, lead exposure, things like that. Whereas the health outcomes was the most impactful for emergency department visits. And then as you see, again, the trend of the 65 plus in the general population, again, there were similar trends where health outcomes was most impactful for cost and the 3M clinical risk grouping. But for the general population, there was also the biggest impact on inpatient admissions. And then for the health behaviors, just a slight difference. And then again, the severity of 3M, the social and economic environment. So when we see just this, the idea that there's a whole suite of outcomes, and there's the suite of how social determinants impact every part of their lives differently. They impact how you interact with the healthcare world differently. So it's not just looking at something and just saying, well, if we fix unemployment, we're going to fix the costs and inpatient admissions and ER rates. It's like that's not really feasible, and it's not really realistic. So from that, I think my next slide is the example of what we would create from these weights for the under age 19 group. So this is now the very specific outcomes after I went from the large overall weights to the outcome specific weights. So here are all the weights that we think that we believe impact overall health for the under age 19 population. You see that the social and economic environment had the highest. We put them into 5% because we want this to go out, or we rounded everything to 5% for the conceptual matrix, because we want to have this available for policymakers, for health plans, for providers, so that way they can see this easily and say, okay, what's really impacting this person's life? What's really impacting the health of the community that I'm serving? So if you go to the next slide, I've highlighted a chunk of this and how this can be used, how we can give this out to people who make these decisions and say, hey, this kind of intervention could have a higher impact, and you could really do a lot of good by going, really thinking about what you're trying to improve and how you're going to improve it. So for example, I highlighted how employment rates, counties with higher employment rates had a higher, or had usually higher costs and things like that. But, unemployment, it burdens an entire community. It doesn't burden just maybe a person or a family. And I think these are things that we're getting into with the world right now. We're understanding how unemployment is getting higher and higher, and it's no longer just houses and families getting affected. It's a burden on the entire community that's having to lift up these people and through hard times, and resources that were probably previously more easily available are getting strained and are losing resources because so many more people are going into it. So it's really something that, how do we help not just only people who are unemployed, but also communities that are being affected most by unemployment, who have been hit the most. And then similarly, the physical environment for the under 19, you see that living in a food desert and severe housing problems has a really high impact on the reportable outcomes for the under 19 groups. And, again, we're seeing that now, where kids were often relying on school for dependable shelter, dependable food, dependable things like that. And whenever that was taken and they weren't able to do that, communities really had to rally around, helping these kids find affordable and good food options, because that usual infrastructure was gone. And so I think that can really help the local and state or in federal policymakers just understand that, okay, this is something we can address. This is something that, like, even when we do address it and we do try to do something to improve it, we can make a big impact, and we can really help out these communities. Next slide. And this is just kind of another example of how you can kind of use these numbers. This is a very easy, when you think about how COPD rates and county smoking rates correlate, you would expect to see something like this, but this is something, these are two graphics from our Health of Texas website that we are creating for the Health and Human Services here at the state of Texas. And so we can go through these types of things of COPD rates or asthma rates or diabetes rates from each zip code and see how it spatially relates to different types of social determinants. This is one that's a very easy linking together, but it's a good example of how we can use these types of numbers. We can finally start to quantify these relationships and really visually see them quickly and get really into the data that could have been, back in the day, probably very squishy data, very loose descriptions or loose relationships. But now we can really hone in on how these relationships actually, how they work and how strong or how weak they may be, and kind of help us make decisions around things like that. And I think that next slide, it should be my discussion. So just kind of going back over, the variation in social determinants was different between age groups and from outcomes. no one social determinant can explain or solve health disparities, which, that's understandable. But it's really important when, policymakers or other health providers or things like that want to go into a community and provide an intervention. Don't just go and provide an intervention. Really think about what you're trying to solve, what you're trying to improve, because that will change how you want to deliver those types of things. So we've proposed these conceptual frameworks that can be used by policy decision makers and insurance carriers and providers to help develop those interventions that are targeted to address very specific populations and social factors. The last two social matrices are at the end of these slides that I believe will be going out to everyone later. So we didn't have time to go through every single one, but if people want to know what we're proposing and what we think could be very helpful, they will be with the slides that will be sent out to everyone. And then next slide, just a couple of limitations, I believe, for the, we only do have the social determinants on a county level. Because some insurance plans and some of the Medicare, Medicaid do include race or income, but and others don't. We couldn't include it in these models because it wasn't, those things weren't prevalent or present in every data source. And then again, we're also losing data on the uninsured populations who may be the most affected by social determinants. So we're
thank you.
Oh, sorry.
Yeah, no, thank you, Carolyn. I'm going to keep us moving.
Yeah.
We do have a jam-packed 1-hour session.
Right.
Thank you. And what I want to do is actually work to take questions. We'll take them with the group at the end. How's that? Does that work for you, Carolyn?
Yes.
Okay, awesome. All right, cool. So, really great beginning to this. We appreciate Carolyn describing social determinants, getting in the same room. And now we have a fabulous next group. We have 3 panelists that have come together, I think, for a really unique description of their work, how data can inform social determinants. We have Jennifer Pooler. She'll be first. She's a senior research associate at Impact International with more than 12 years of experience conducting social science research and program evaluation in the areas of food assistance programs and food security. Then I have Elisa Wong. She is the National Program Lead for Social Health at Kaiser Permanente's Community Health Department. And then finally is Dr. Nrupen Bhavsar. He's a qualified epidemiologist with methodological expertise, and he has backgrounds in measurement and characterization of biomarkers, risk factors, and treatment outcomes for chronic disease using real-world data sets. So we're gonna move to the panel. They're gonna take themselves through. Please keep the questions coming, and we'll deal with those toward the end. Jennifer, you're on.
Good afternoon, and thank you, Sarah. As social determinants of health gain greater, prominence and focus in just about all aspects of public policy, I think a first step for a lot of us is really figuring out what data are available. How do we identify and acquire those data? And how can we use those data appropriately and meaningfully to address some of these complex social issues? So our panel is going to provide some insights on these questions by using examples from our own work to describe different types of data, different ways in which we've used the data, and how these activities can inform policy that's relevant to social determinants. So I'll share an example from our work at Impact on how we're currently based on the types of food that they have access to and can afford. Community factors are also very important. Do people live in close proximity to stores? Is there transportation available to them, either their own vehicle or public transportation that can help them easily and conveniently get to those stores, or are they relying on local convenience stores for a lot of their food? Other factors, I think we can all probably think of at least 10 personal factors that contribute to our ability to consume a healthy diet, from our food preferences that start in childhood. I think most people can relate to that. The environment in which we're raised really impacts our preferences and what we like to eat, especially, on days you need comfort food. But that also includes the ability to cook healthy foods. Do you have access to a working stove? Do you have access to refrigeration so that you can store produce and other foods to make fresh meals? So on the next slide, we really, did we skip a slide? I'm sorry. Thank you. There we go. Maybe that was up before. The problem has really been exacerbated. All of these challenges have existed for a very long time, long before March of 2020, when many communities across the country started struggling with rapidly rising unemployment, school closures that cut off school lunches and breakfasts for many children, stay-at-home orders that prevented people from accessing the grocery store at times that were convenient to them, or at all in the case of public transportation closures. I think it is, probably an understatement to say that COVID-19 really created new challenges to food access, and for many people who might not have struggled with these issues in the past. So in this new environment, my colleagues and I asked the question, how do we ensure that the people who need food receive it? And how can we inform the many, many organizations, programs, policies, and other activities that sprung up all at once, seeking to alleviate hunger? So on the next slide, we decided to try and create a food access index. We know a lot about food security. I think Caroline pointed out on one of her slides that they had county level data on food security from Feeding America's Map the Meal Gap. And that's one measure of access to food, but it's also at the county level. And we really wanted to try and identify communities that are at highest risk of having limited food access. So if you are a local service provider, you could look at where meals are being delivered or where your food pantry clients are coming from and figure out if you're really hitting all of the communities that are hardest hit. So our aim was to look at census tracts, which is probably the closest we could get to the neighborhood level using publicly available data. And so our first step in the process was to look at what factors really are contributing to limited food access, and that includes much of what I've just discussed on the past few slides, and as well as in this new context of COVID-19, there may be some additional factors that aren't linked to limited food access yet, but could prevent people from getting to grocery stores, or maybe they rely on a neighbor to do their grocery shopping for them, but their neighbor is high-risk population and so isn't willing to make those trips again. And then, of course, we need to identify the data that are publicly available. We don't have the resources to collect census tract level data across the nation in order to inform this index, unfortunately. But the data also need to be able to distinguish between communities. If the data can't distinguish between communities, then the index really doesn't tell us much. The graphic on the screen is not ours. That I put up there so that you have an idea in your head of what we hope this food access index will look like. This is actually from CDC's Social Vulnerability Index. And a lot of our work is based on what they have done. And just briefly, their index was developed to help people planning for responding to disasters by identifying census tracts that might be most vulnerable to the effects of natural or other disasters. So on the next slide, I've listed some of the sources of publicly available data that we've used. The Census Bureau's American Community Survey is just a wealth of information, as people probably know, on demographics, socioeconomics, and a wide range of other data points. The Food Access Research Atlas we also use that Caroline mentioned, Bureau of Labor Statistics, of course, is important for employment. And then we had some data from the National Center of Education Statistics that was important to us for calculating school meal eligibility and participation at the local level. On the next slide, I just briefly summarize the methods. As I mentioned, the Food Access Index isn't finished yet, but I did want to point out that I thought it was important that we consult with experts in food insecurity and organizations who are involved in the work, so that we're not excluding any important indicators that might influence food access. And their help was pretty vital to coming up with our final list of indicators. We're currently in the variable reduction phase, so we're trying to eliminate some redundancy and really pinpoint those indicators that will distinguish between communities that will go into our final index. And the final phase will be to visualize the data. So on the next slide, I think I'm running out of time quickly, so I will not go through all of this one. Our aim is really to allow policymakers, program services, and others seeking to address hunger in their communities to easily identify where there is limited food access. So a data visualization tool like Tableau really, I think, makes the most sense in doing this. We don't plan to print all of the publicly available data and have people sift through it, but we hope to be able to rank census tracts based on their relative risk for limited food access. So I don't know that we will use a red, yellow, green kind of coding system, but it's kind of that idea. It'll be easy for people to see, if I look at my county, which census tracts are at the highest risk, and where I might want to divert resources or stage interventions to address food access. So my last slide, I just wanted to talk briefly about some of the benefits and challenges of working with publicly available data. Obviously, by definition, they are cost effective. It saves a lot of time and resources if you can find data that are available that meet your needs. Oftentimes, they're comparable across years and geographies. Most of the time, the limitations are very clearly stated. So you know that you are comparing apples to apples and not apples to dragon fruit. And then they can also be useful for covering large geographic areas systematically. The challenges, of course, are kind of the flip side of this. Often what you find available is close, but not quite what you're looking for. And so a lot of times working with publicly available data, you're really looking at social determinant or proxies for social determinants. And that can have its own benefits and challenges. If you're focusing on smaller geographic areas, sub-state, you might not be able to find publicly available data that's granular enough. If you are really interested in neighborhoods or census blocks in smaller geographic areas, it might be more reasonable to collect your own data or just to use other sources of data that are not public, so administrative data or electronic health record data if you have access to. And I will go ahead and pass it on to Elisa. Thank you.
All right. Thanks, Jennifer. So hi, everyone. I'm Elisa Wong. I'm with the National Social Health Team at Kaiser Permanente. And for those of you who may not know, Kaiser Permanente is a not-for-profit integrated healthcare delivery system. We serve 12.7 million members across the country in 8 regions. And we are a unique model in the sense that we both insure our members and also provide their care. And so from a data perspective, we have access to, I would say, rich data systems, which if we do our job well and combine them together, really could help us, I think, provide a lot of insight into this issue around social determinants and what we know about kind of the social health of our members and their health outcomes. So today I'm going to talk a little bit about that. We, of course, are a provider of both physical and mental health services, but social health really, as Caroline and Jennifer already have kind of laid out, it's critical for us to address social needs of our members, given that social factors like access to healthy foods or having a safe and stable home really have this, outsized impact on health outcomes and overall well-being for our members and those individuals who are living in our communities. I'm going to frame this up as really kind of thinking about social factors at the individual level, then at the local or community level, and then at the societal level, and our efforts to have strategies that really work at each of those levels and how they're informed by data. Next slide, please. So at the individual level, I mentioned that we serve 12.7 million members. That's a big number. So we really need scalable approaches to identify who may be at risk for social needs. That is the first step, of course, in being able to support them in addressing those needs. And so on the identification front, we're doing a few things. We're developing predictive models to first identify who may be potentially at risk. And then we follow that up with screening and assessment. So maybe a little bit more old-fashioned sort of outreach to folks who maybe have risk, and have a conversation with them and actually talk with them, or have a digital conversation with them to understand, are they experiencing these now, and would they like our help in supporting them in addressing those needs. That, of course, requires us to, understand what their context is and what their situation is, and then we can connect them to either resources that we as a healthcare delivery system can provide, or connect them to resources in community. And on the connection front, we have a major initiative that's called Thrive Local, that's being carried out in partnership with a company called Unite Us. And Unite Us provides a technology platform that allows what we think of as sort of electronic referrals that is done through our electronic medical record system. And we do that as a healthcare provider. We make a referral to a community-based organization. And of course, it's the community-based organization that is the one who's actually providing the resource, whether that's a local food bank, maybe that's helping a member with emergency food, or maybe a housing shelter that's helping to support a member find stable housing. And through that technology platform, we'll be able to get what we talk about as closed loop referral data from the community organization about each referral. So we'll know what services or program or intervention was provided and how that referral was resolved. And we're still in the early stages of that work, and we're rolling that out. As I mentioned, we have many markets and services, and each of these community networks has to be developed at a local level, because those are all local community-based organizations who have to agree to work together on a common platform. But as we get that work going, you can imagine that we feel that data is going to be really valuable to us, that closed loop referral data. At an individual level, we'll be able to examine, the efficacy of specific resources in addressing that particular member's social need, and of course, what else we can do for them if their need hasn't been resolved. But also at a population level, we'll be looking for improvements in various metrics of interest, for example, improved health outcomes or well-being. Certainly we'll be looking at things like care utilization, and also other important metrics like member satisfaction and provider satisfaction, and other sort of dimensions of care team and how our system as a whole is able to support the broader needs of our members. And we imagine we'll be able to use that kind of data, especially at a population level, for two purposes, both for refining our strategies. So what kinds of resources should we provide for members who have a specific need or risk profile, if you will. And so as we learn about, for example, providing resources for members who are experiencing food insecurity, and maybe, like Jennifer mentioned, there are specific factors that make an intervention more viable for some members than others, depending on, access that they have to local food resources and cost and cultural congruence of available foods and so on. So we'll be able to look at how to refine our strategy based on what we understand about what's working. But of course, we also want to contribute to the evidence base, and from a research perspective, at a population level, what kinds of resources, what kind of interventions are working, and what are the health outcomes at the end of the day. Next slide, please. I'll just mention briefly that at a community level, we have a long history of course, conducting community health needs assessments and relying on many of those public sources of data that Jennifer mentioned as it relates to food. We also do engagement, a qualitative kind of engagement with community groups to better understand the quantitative data, if you will. So, maybe understanding which specific populations or geographic areas are experiencing greatest inequities and why, and what's driving that. And we bring together that community health needs assessment data, both about the gaps, but also about, assets that we know are in our communities. We combine that with what we understand around our own members and their needs around social and their own social needs. That helps us set our priorities as an organization. So you see on the right there some of these major areas where we're deploying resources. And those resources are both charitable contributions and grants, but we also have impact investment dollars and other partnerships that we are trying to activate in order to make a difference in these spaces in our communities. And then as we deploy more of our Thrive Local community networks, we'll have an even more, I would say, localized and real-time view of where there are strong ecosystems of community organizations and assets, and then where there are gaps in community resources to address our members' needs. And that might be because we can hotspot gaps in specific services. Maybe it's around food, maybe it's around transportation. And all of that data together will really further inform our strategies and our investments. Both to bolster local community capacity, but also to pursue broader systemic change. And that's the last slide that I'll just speak to, which is at the society level, the third prong of our strategy. And here I've just included a couple examples of policy work related to food insecurity and housing instability. Our policy work is really undergirded by, the various types of data that you can imagine. I've mentioned the community health needs assessment, and both food and housing are priority needs across, I would say, almost all of our markets. And of course, we know that there's literature that associates the presence of these needs with higher care utilization. And as a healthcare delivery system, as an insurance company, that obviously matters a lot to us. But I will say probably the most valuable data that we can bring to this work is the population level insights from our own 12.7 million members. And that's, we have data around prevalence of needs among our members. We're just wrapping up a member survey, representative sample, 10,000 members across all of our regions, and we can break down that data by race, age, line of business. And we've also conducted targeted analyses of our member social risk and utilization, and looked at the kind of places where we have Z codes and how is that correlated with utilization and cost of care. And then finally, we have first-person accounts from patients who tell us stories about how these social factors have a direct impact on their ability to care for their own health and the health of their family members. So, our member data, I would say, both drives us, and gives us credibility to make a data-driven, a science-driven, and a humanized case for addressing these sort of societal and systemic barriers. And that's both to benefit our own members, which we care deeply about, but it's also to improve social health in the nation at large. So I'll just stop there, and I know I was asked to mention challenges and barriers, but I'm happy to address that in the Q&A section if that's of interest. Nrupen, over to you.
You think you're on mute.
Sorry about
There.
that. There had to be one snafu. It had to be me. So I'll do my best to anchor all of these talks with the conversation around using social determinants of health data to understand individual health with EHR data. Next slide, please. So I think we've had a lot of discussion over these previous talks about how the local environment impacts behavior, and this in turn impacts proximal clinical factors like hypertension and diabetes, which in turn affects long-term health outcomes like cardiovascular disease. Next slide, please. And there are multiple initiatives across the country that are interested in defining the health of neighborhoods. And I think many of us are well aware of the BRFSS, which is a survey of around 400,000 people across all 50 states that aims to understand the health of individuals in neighborhoods. But there are also many local initiatives that take place that are interested in health outcomes at hyperlocal levels. Next slide. And many of these initiatives capture static snapshots of neighborhoods. And what a lot of my research is focused on is understanding dynamic changes to neighborhoods through forces such as gentrification. And gentrification is one of those things that we sort of have an understanding of when we see it. And so if we look at a street corner in New York City and we see what was then an Alligator shoe store back in the late 80s, and now we see a Whole Foods, we say, well, that is probably an effect of gentrification. But how do we define this, and what are the theories on how this might impact health? And the approaches that are used to understand the impact focus on measuring a couple different aspects. One is the increase in neighborhood wealth and resources due to the influx of healthier, wealthier, and younger individuals as a potential positive effect. And there are some negative consequences that are also of interest, including the physical displacement and breakdown of social cohesion or connectiveness of individuals within a neighborhood that result in longer commute times for individuals or displacement of small businesses by big box stores that impact health potentially through greater stress, inflammation, and the inability of people to manage their health. So there might be both improvements in health and deteriorations in health. Thank you. Next slide. And so some of our work has focused around how do we define it using publicly available data, such as the American Community Survey. And so my colleagues and I conducted a comprehensive review of current gentrification definitions, and they all broadly focus on measuring 4 or 5 distinct constructs, including income, housing prices, population that is within a professional, within a profession that is considered professional, and the proportion that live below the poverty level. And they measure neighborhoods that are eligible to be gentrified, and this often includes neighborhoods that are below a median socioeconomic status. And then they look at change across 2 time points, and the change in a positive change in aspects like income, rent, and the proportion that is within a professional occupation, or a negative change in a poverty level would indicate gentrification. Next slide, please. And so we take these data and we link it to our EHR data using FIPS codes at usually the block group or census tract level. And this allows us at Duke to create a unified data source and to bring in these measures of social determinants of health within our EHR and allow our researchers to essentially pull data sets that include both elements, both the social determinants of health aspects and the EHR clinical measures. Next slide, please. And so I'll talk briefly about one specific project that we've worked on where we link together social determinants of health data and EHR data. And when I talk about EHR data, I'm talking about two distinct health systems that are connected, though distinct systems. One is the Duke University Health System, which includes the major academic medical center and two community hospitals. And then also Lincoln Community Health Center, which is a federally qualified health center that serves the underinsured, and undocumented residents of Durham County. And together, and their data are linked through an EPIC system. They cover about 90% of Durham residents and providing broad coverage of the county to allow us to get a good understanding of how various social determinants of health impact our residents. Next slide, please. For this project, the health outcomes that we were interested in were proximal health indicators, including diabetes, hypertension, obesity, cardiovascular disease hospitalizations defined by myocardial infarctions and stroke, and then healthcare utilization, including ED visits, inpatient, outpatient encounters. And what we learned, and I just want to go over briefly, was that certain health aspects, certain proximal indicators changed over time so that patients living in neighborhoods that gentrified had a higher or greater change in diabetes prevalence than those in neighborhoods that did not gentrify. And then conversely, for hypertension, we saw that patients living in neighborhoods that gentrified had a lower prevalence over time, lower change in prevalence than individuals living in neighborhoods that did not gentrify. And for long-term outcomes and for healthcare utilization, we did not see any differences by where individuals lived. Next slide, please. And so what I really wanted to touch on was some of the benefits and challenges of using these EHR data for these type of research. And others have touched on the fact that they're cheaper and faster to access. They're a broad collection of data elements, including demographic information, clinical information, and increasingly social determinants of health data. And there are important challenges to note. I mean, these data are dependent on patient interactions for the health systems. And our own research has shown that the people who interact with a health system are different, especially in terms of socioeconomic status, than those that don't. We try to counteract this by including the federally qualified health center, which does afford care to those without means to get access. The other aspect of this is that residents move and receive care outside of their own health system. This is something that's we're acutely aware of where we are, because we have another academic medical center down the street, and myself and lots of individuals within our community receive care across both health systems. And then the data curation process requires an interdisciplinary team. Much like the panelists that we have, we're all multidisciplinary and require expertise across informatics, epidemiologists, like myself, statisticians, clinicians, and we actively try to engage with the community to participate in our research. Next slide, please. And I'll close with just understanding 3 different ways that we at Duke are trying to engage with our community to inform health policy. One is through communication of how social determinants of health impact their health through an online portal called the Durham Neighborhood Compass that allows the community to visualize the data, link the social determinants of health data and the health encounter data at a high level, at a summary level, in an intuitive process where they don't need any deep training to do that. We also use our EHR data to identify populations in need and provide interventions. One example of this is a clinician at Duke who's working to identify patients experiencing homelessness and provide medical respite for them. And then lastly, through active participation. And so we conduct focus groups to identify the most pressing social determinants of health, and then we actively seek out community members to participate on grant and project teams. Next slide, please. And I'll just like to acknowledge my collaborators in this process and my funding sources. And I'll close with that to start the Q&A.
Thank you, Nrupen. This is, you guys, a fabulous group of folks describing the entire spectrum of social determinants data and different uses. And I feel like we could spend another hour in questions. I want to let Norm let us know, are there any questions in the chat that we should take in those last few minutes?
Yes, we have 5 questions. Let me just read all 5, and then we can come back to the ones that you've prioritized. So the first one is, for Caroline's session with Texas data, the list of weights as determinants was long, with several in each category. How does the researcher assess the interrelationships among so many factors? That's question 1. Question 2, I think also for Caroline, but not sure. Did you see differences with regards to race and ethnicity within age groups? Number 3, how can Kaiser's approach be applied to physician practices that are not part of an integrated delivery system? And then please repeat the name of the referral technology platform for the Kaiser Permanente community partners. And then the last one is, how is food insecurity defined in a survey? Which would you like to take first, and who do you want to do it?
Caroline, let's give you a chance to respond to those couple of questions as briefly as you can. The good news is we have links for these guys so you can talk to them offline. But Norm, do you want to brief her on her question again?
Sure.
Her first question?
For the first question was had to do with weights as determinants. How do you assess the exponential interrelationships among so many factors?
That's a great question. That's something that we're working on currently with future projects. This was really a starting point. We did run a few collinearity tests just because there were so many variables. The only things that really had very high relationships with each other were a lot of the access to healthcare variables. So we did reduce it down to the ones that we felt were most applicable to these outcomes. For example, we had mental health, maternal health access, dental access, things like that. And for the dental, we decided to exclude because we don't have any dental claims in this set. But we're working definitely to get a bit more focused in what variables we use for future projects. Specifically, we're doing it this similarly with some HEDIS measures. With the state Medicaid data, and we're really trying to parse down this list into something a bit more feasible, I would say, and what that it's that gets to the parts that if you get to food insecurity, you're really affecting food insecurity, food access, food deserts, things like that. So those are some of our next steps for sure. And then I think my second question was about the racial disparities. I tried to answer it in the chat very briefly. In this project specifically, we were unable to make those kinds of comparisons because sometimes the commercial data set, I believe, does include or does not include racial indicators for any of their members, but then the Medicare and Medicaid did. So because we couldn't make that comparison across all of the databases, we didn't do it here. However, like I just previously mentioned we're doing something that's specific for the state Medicaid. And so in that one, we are including racial disparities just to see how the social determinants are affecting them differently. And we're seeing some very interesting results from that.
Thank you, Caroline. Norm, let's give Elisa the question for Kaiser.
Yes, we have two questions about the Kaiser. One is, how can Kaiser Permanente's approach be applied to physician practices that are not part of an integrated system? And then could you please repeat the name of the technology platform that you used?
Sure. The technology platform is created by the Unite Us organization. They're a vendor out of New York. And I think the first question is really interesting, and I'm not sure I have a perfect answer, but I would say there are a couple of things that I think are still really important to do from a physician practice perspective. Screening for social needs is such a critical component of an overall system to support patients with their social needs. So even figuring out, are there some core questions to be able to screen for social needs? And then there are, I would say, some independent groups. I won't name them all here because they're probably competitors of each other, but there are some independent groups whose mission is to be able to connect patients to community-based resources. And so I think there might be a little bit of sort of piecemeal work for until there are broader collaborative coalition-like efforts to do this work. But there's certainly baby steps around understanding what patients' needs are and then figuring out how to connect them to local resources. That is all worthwhile work.
All right, I'm going to go ahead and thank everybody for speaking today. Please remember to do your survey. Please know that the slides are available. In addition, a lot of resources from the panelists at the end as well. And again, this is jam-packed. I think a very excellent introduction to all this work, and every single one of you should be presenting a full hour next conference, right, Dr. Thurston?
That's correct.
All right, excellent.
Just a real quick plug. In 10 minutes, we're going to be joining with NASHP on NASHP's platform to listen to Governor Charlie Baker of Massachusetts. So please look for that link. You're going to have to leave our platform and join us over at NASHP. We'll see you all there.
Thank you very much. And again, all the panelists, thank you so much. Enjoy your respective next steps. And thanks for everyone who attended today. Really, really thank you all.
Thank you.
Okay.
Thank
Bye-bye.
you.